So this next group of drugs are also sodium channel blockers, but as you'll notice as you go through these lecture slides, the first part talks about blocking the sodium channel, and the second part talks about another mechanism. A lot of these drugs, especially in the CNS, have dual or triple mechanisms of action, and so all of the known mechanisms are listed, and I try to categorize them by their primary effects. And so the next group of drugs are sodium channel blockers, but they also offer some other mechanisms that kind of pertain to the treatment of epilepsy. So valproic acid is another kind of old drug. It's got several mechanisms. It'll block the sodium channel. It'll inhibit GABA transaminase, which is the catabolic enzyme for GABA. It also probably has an effect on the T-type calcium channels. Maybe, we're not sure. Valproic acid is a really simple molecule. It's a fatty acid. It's got low potency, and so in order to have excuse me, in order to have any type of effect, you have to give hundreds of milligrams, and this also has a potent cytochrome P450 enzyme inhibition. From a clinical standpoint, you can use valproic acid for several seizures, and we'll revisit this drug in the psychiatry component of this course. You can use it for mania as well as bipolar disorders, and it's also been shown to prevent migraine. This is another drug that's teratogenic. Women that have taken valproic acid while pregnant will sometimes produce babies that have spina bifida, and it's got some relatively nasty side effects: liver toxicity, including hepatitis, thrombocytopenia, as well as pancreatitis. The next drug here is carbamazepine. This is another sodium channel blocker. Also has the ability to block adenosine receptors as well as norepinephrine reuptake receptors. Clinically, it's indicated for several different seizures, neuralgia, as well as bipolar disorder. So we'll revisit this drug again. Side effects include CNS depression, osteomalacia, blood anemias, double vision. It's also a potent teratogen, producing cleft palate and spina bifida. And then there's a well-documented risk of a rare reaction called the Stevens-Johnson syndrome in patients that have a specific HLA phenotype. This diagram is a great diagram because here what we're looking at is the recordings of a seizure, and then the effect of phenytoin, carbamazepine, and sodium valproate, which is valproic acid, basically, and how these drugs attenuate or reduce the recordings associated with the seizure. And you can see phenytoin is almost an instantaneous inhibition of this of the seizure, followed next by valproic acid, and then thirdly by carbamazepine. So I think this is just kind of a nice way to look at the potency of these drugs and their effect on kind of reducing the seizure focus. I want to spend a little bit of time on carbamazepine because it also has some unique pharmacokinetic attributes. Carbamazepine is unique because it is an inducer of CYP3A4, the enzyme, and it's also a substrate for CYP3A4. And so this is kind of unique because this drug has the uncanny ability to induce its own metabolism. And so what does that mean clinically? Well, it's quite significant. Over time, the patient is going to need more drug to produce the same effect or to produce some type of treatment. And so this is a really good example of a pharmacodynamic interaction. So here's typical carbamazepine biotransformation rate. This is carbamazepine given on day 1, and here's the standardized kind of rate of biotransformation. Now what's interesting is that when you look at what carbamazepine on day 50 looks like, you can see that the biotransformation rate basically gets shifted slightly to the left. And so the rate of biotransformation of this drug gets dramatically increased. And so On day 1, carbamazepine 200 milligrams has a half-life of approximately 35 hours. But by day 50, 200 milligrams of carbamazepine has a half-life of only 15 hours, meaning that the rate in which this process occurs gets dramatically increased. And that's because the enzymes have been induced. Likewise, if you look at the plasma concentrations of carbamazepine on day 1 versus day 50, you see a dramatic reduction in the plasma concentration of carbamazepine after the drug has been given routinely for 50 days. So what does that mean? So clinically, over time, we would have to increase the dose in these chronically treated patients to kind of get that same benefit because we have this enzyme induction occurring. So there are major consequences to CYP induction, and this is really important because this basically lays the foundation for drug-drug interactions, and we're just kind of using carbamazepine as a tool to teach this process. Medical students and pharmacy students as well always want to memorize the outcome to CYP induction, and you can't because there are potentially there's 3 listed here, but there's potentially 5 or 6 physiologic examples of CYP induction. And so the 3 that I posted here are kind of the most relevant and the most commonly occurring. So when the CYP enzyme is induced, you can see enhanced activation. And so this occurs when you have the same drug as a substrate and an inducer. And so verapamil fits into that category, barbiturates such as phenobarbital as well as carbamazepine. And so that's kind of the classic example for that particular outcome. You can also see enhanced inactivation of a co-administered drug. And so the inducer, so in this case carbamazepine, could induce a CYP which transforms the co-administered drug, so drug B, into something less active. So good examples of this include phenobarbital with warfarin, and so the outcome is insufficient coagulation. Another good example would be phenobarbital with oral contraceptives, which are recombinant estrogens or progesterones, and that translates to reduced effectiveness of the birth control, resulting in unwanted pregnancy. Another example would be a CYP3A4 inducer like phenobarbital again, with an immunosuppression like drugs such as tacrolimus. The outcome here would be reduced efficacy of tacrolimus, leading to transplant rejection. And so all of these would be examples of enhanced inactivation of the co-administered drug. Okay. And then thirdly, there's enhanced toxication of a co-administered drug after repeated administration of the inducer. So the example here would be, and it got cut off at the bottom, but essentially what we're talking about is ethanol with acetaminophen, making that one metabolite called NAPQI, which is hepatotoxic. And so all of these are potential outcomes and consequences to CYP induction. That's why memorizing drug-drug interactions are so problematic and seemingly impossible with the ever-growing body of drugs that are coming out into the marketplace. So what we do is we teach you some of the main ones, but understand that you can't kind of reason through some of these. You just kind of have to go through a step-by-step and looking at some of these outcomes. And so what I will do is kind of throughout the curriculum, when we talk about these specific drugs and these kind of well-documented drug-drug interactions, I'll bring this back again and again. I wanted to do it with verapamil in the cardiac block, but there were just too many drugs in that unit to even attempt to do this. And so next year, we'll spend a lot more time talking about drug-drug interactions, and you'll basically be able to memorize the top 10 or 12. And we'll try to reason through some of them. Some of them can be reasoned through, some of them cannot. You just have to memorize them. And so we'll spend a lot more time on this. But this is a great kind of segue into that topic.